So communication, reporting, physician to physician, as I said earlier, and facility to facility, and physician to physician from the hospital physician, if it's a hospitalist, to the family practice if that person's in the community, or to the home health medical director, or to the attending physician in the long-term care arena. So we've looked at all of those things. It's important to continue to look at those, but they're either difficult to do or they haven't made much difference. So what works? So here's an article that measures what works. This is from this summer, and it is a featured article in a nursing journal on palliative care. So this is nurses, and I think that's important to say. So these nurses in Connecticut looked at patients in hospitals to see what might be done to just improve a couple of parameters, like length of stay, cost per case, and readmissions. So the average readmission rate in the country, Edna, about 18%. Good would be about 15%. Much less, you think? How low do you think? 9. So 9% would be lower. So I think that's probably right, that the range is from 18% or probably much higher in some hospitals, all the way down to 9% would be the readmission rate. Florida ranks at the lowest, and so we would like to improve the readmission rate. And why to do it? My talk: lowers cost, improves quality. And what's the quality? It's what the person wants. So today, we have all, whether we're talking about MOLE, POST, 5 wishes, My Life Choices, any advance directive, it is in advance of a crisis, what are my directions for the care I want to get? That's what an advance directive is. So we've all talked about documents, perhaps too much about the documents and not enough about the root problem. What does that person want? Now, whether it's most or post or another, it's just a way to document what that person wants. So in this study, the nurses screened 300 patients, 287 or so, in order to get to talk to patients about what they wanted. And in this conversation, it was called the Goals of Care conversation. What would your goals of care be for the rest of your life if you realize the situation you're in now and how you got here? So it's Goals of Care conversation. So we can call it patient choices, we can call it their advance directives, but it's what they want. It's the kind of care they would want for the rest of their life. They ended up with 94 patients. They screened over 300, about 300, and they ended up with 94. And when they had the discussion, the conversation with those 94 patients, they asked them their choices, their wishes, and the results were that they reduced the length of stay in those patients by 50%. Now, these were long-stay patients because they were very sick patients. Remember, in the LACE, L-A-C-E, L is the length of stay, and the longer the length of stay, the more likely for a readmission or death. So these were very long length of stay patients, but in the patients they talked to compared to the rest of the population in those hospitals, they reduced the length of stay by 50%. They reduced the cost per care, and this is where hospital CFOs might not like this result, but in those patients that they talked to, they reduced their cost by 54%, their hospital cost. And one of the quality markers is reducing the cost. So what do you think happened to the readmission rate? It went down 4.4%. Even if 9 is an incredibly wonderful number, not 18, not 15, but 9, it was 4.4%. But there was a problem here. They screened 300 patients and they got to talk to 94. They hoped for 100. Why do you think the other 200 patients did not have the conversation? They said, I don't want to talk. What do you think was the obstacle? What got in the way of 2/3 of the patients having the conversation? Doctors. Doctors got in the way. Doctors would not allow them. They're not ready for that yet. We're still curing them. I'm in the intensive care unit. It was the physicians in the hospital that were the obstacle to the conversation. And we know, I will tell you, in palliative care, we are rejected all the time because they confuse palliative care with the last day of life care, not with a discussion about choices. And so physicians are the major obstacle to having the conversation. Should we have the conversation? Now, the Conversation Project is a community conversation. It's not a clinical conversation. Thanksgiving is the time to sit down at the table with family and say, before we pass the cranberry sauce or whatever it is, how do you feel about your life? But here are metrics. This is really one of the very first articles. And by the way, I started off by saying this was nurses, because nurses saw the value in this. Physicians blocked in 2/3 of the cases the opportunity, and they saw that as the major obstacle in getting to 100 patients quick. It's the docs that are in the way of this. But the studies show, and the metrics are clear, having a conversation and asking a person what they want for the care for the rest of their life gets not only the quality numbers, the patient-centered, person-centered numbers, but the cost numbers too. Reducing length of stay, cost per case, and the readmission rate. So I'll be happy, we can, through FMDA, make that article. We'll even reference that, I think, in our upcoming progress report, which we have online. So we'll make that article available to you, or you can contact me. But it is a measurement of the result. It is what works. Now, we've talked about a lot of very important things, and we have important contributors to the solution right here. But getting on board with what works to reduce admission is getting on board with person-centered wishes. So thank you for allowing me to be here.
Well, I would like to thank everyone for their participation and joining us and the questions that we've had. I'd like to thank the speakers for an excellent presentation. And as we started this afternoon off, we talked about what the challenges were, and as we ended, we're looking at what the solutions are. And a lot of it is having a collaborative effort amongst many different organizations, of which they're present here. And I want to thank you all for the interaction. Dr. Kaplan?
Steve, I just want to make one point from the SNF perspective. Leonard, you had spoken about looking at potentially avoidable readmissions. And one of the first steps, again, is looking at why the patient went to the hospital to begin with. And obviously doing an exercise like root cause analysis. And what I would advise is try to get everyone, and I mean when I say everyone, up to the top, the medical director, to get involved with that chart review. As we all know, within 1 to 2 years, the nursing homes are going to be dinged for readmissions, etc., just the same way hospitals are today. And I can tell you there's a huge difference in the eventual decision, avoidable versus unavoidable, depending on who does that chart review. If you have the top being with the utmost due respect, the RN level, you're going to have huge difference whether it's an additional level of clinician expertise going to NPs, PAs, and eventually physicians, being the prototype being the medical director. So to truly look for those opportunities for improvement, we need to engage everyone, including the medical director.
Thank you very much. And if there's no further comments, I'd like to bid everyone a safe travels home. Stay off of I-4 as best you can.